This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I am sitting here this morning with Dr. Jeremy Cannon, one of our CSAP 17 authors. Jeremy, before we really get started, can you share with our audience a little bit about yourself, where you're located, your primary focus of your clinical practice, and maybe a little bit about how you spend your usual day or week, if there ever is one of those?
I'd be happy to, Dr. Weigelt. So I'm the Trauma Medical Director at the University of Pennsylvania, and I play all the positions in critical care, trauma, and emergency general surgery, including weeks on service for the trauma team, weeks on service for emergency general surgery, and then weeks in the ICU. We actually cover 3 different ICUs in our system. We have a trauma ICU at Presbyterian Hospital, which is now the epicenter for our trauma program. We also covered the surgical ICU at the hospital of the University of Pennsylvania. And then I spend some time over at the Philadelphia VA Medical Center, where I work in the ICU there. So that's what I call my civilian day job. And then I'm also a reservist in the U.S. Air Force, and am currently serving in a position where I am able to help make policy for the military health system.
Sounds very exciting, and thank you for your service. All of you that protect our country deserve a lot more than you get, but I truly want to thank you. Well, let's start this for our audience, and I'm going to lean on your critical care knowledge today. Most of the topics we are going to discuss are from the critical care category of CSAP 17. Most of these will be right from CSAP 17 questions, although there's going to be some that I'm going to ask you about that were not necessarily selected for the final draft, but I remember a lot of discussion among the committee members when we discussed the question, and that's always fodder for a good discussion. So that's my plan, and let's get started. So I have 2 conditions that seem to confuse a lot of people. One is called TRALI, and one is called TACO. What are they?
So it's a very interesting topic, and one that I spend a lot of time thinking about. Thankfully, I don't spend a lot of time managing them because they're rather infrequent, but when they do happen, they're quite dramatic. So the first one you mentioned, TRALI, transfusion-associated acute lung injury, is really thought to be an inflammatory process that results in a very rapid progression to hypoxemia, typically shortly after a blood product transfusion. We generally see this after an infusion of a plasma-based agent such as FFP, or even platelets have some plasma in them, but you can also see it after a red cell transfusion. It's thought to be a non-hydrostatic pulmonary edema, so inflammatory mediated. Our best understanding of the mechanism by which it happens is an inflammatory response to donor antibodies. And so through mitigation strategies in the blood banking world, the incidence of this has really decreased pretty significantly in recent times, but has not been totally eliminated. The other condition you mentioned, TACO, transfusion-associated circulatory overload, is more of a hydrostatic process where the patient simply gets rapidly volume overloaded, generally in the setting of a massive transfusion or resuscitation, or in an elderly patient that just doesn't have the cardiopulmonary reserve to handle the volume given.
I would agree with you that TRALI seems to be much less frequent than it used to be. What do you think about TACO? With all our changes in our resuscitation approach, do you think that TACO is something that we see less of?
I have to say we've had a couple of cases in our practice in the trauma program at the University of Pennsylvania, and it generally comes up in the setting of overestimating the amount of bleeding and not turning the faucet off on your resuscitation quickly enough.
Is there a way to really differentiate between these two early in the course?
It can be difficult, but the cases I've seen of TACO have been pretty dramatic, where you see this frothy output from the endotracheal tube, almost like foam coming out of the ET tube. Whereas TRALI tends to be more of a drop in the oxygen saturation. You get a chest x-ray, it looks like diffuse pulmonary infiltrates consistent with ARDS, but no real inciting factor that would lead to ARDS other than the blood product transfusion.
I've been impressed with Trolley that many times that first chest X-ray, if you jump on the hypoxemia early enough, looks pretty normal, except maybe a little atelectasis. Is that your experience or not?
I would say so, yes, where there's sort of a progression over several hours. So if you get a super early acute X-ray, say even in the ICU shortly after coming up, it may not be as impressive.
So now we have two scenarios, a little different etiology. Does the treatment vary too?
The treatment is generally supportive. If you suspect Trolley, and often in a TACO situation, you're also possibly suspecting Trolley because the patient has received blood products. You stop whatever transfusions might be currently being performed. You then alert your blood bank to the fact that you have a potential transfusion reaction, and then they go through their process of requesting specific labs, and then they also actually reach back to the donor pool and find out if there is perhaps a donor that has antibodies that would potentially cause Trolley.
Is diuretic important in TACO?
It is. So sometimes maybe not in the hyperacute setting, but if you feel like it's really a hydrostatic process and your imaging, say bedside ultrasound or echo suggests cardiac strain or hypervolemia, you certainly could give a diuretic for sure.
Is there anything we can do to prevent these two besides turning off the spigot?
Well, in Trolley, as we mentioned, the mitigation strategy that the blood banking community has implemented seems to have been very effective. Specifically, they've eliminated women that have had previous pregnancy from the plasma donor pool in particular. So that is a far upstream mitigation strategy, but seems to have been effective. For TACO, you really just have to be very thoughtful about each and every blood product unit that you give, especially in an elderly patient that might not be able to tolerate the rapid volume expansion.
Okay, let me ask you, especially for some of our younger listeners, we used to use blood filters on every unit of blood that we transfused. We don't do that anymore, at least at our institution, we don't do that. How about you?
They tend to come to us in a format where all the concerning elements have been filtered out, to include our whole blood program where it is leukocyte reduced, and so the filter has already been applied, and then by the time it gets into our blood refrigerator, it's pre-filtered. So we don't end up doing that at the patient's bedside anymore.
Okay, now you just enticed me to ask another question, and that was, so you have a whole blood program at the University of Pennsylvania?
Yes, we do. It's limited to our trauma patients, but our blood supplier, the American Red Cross, is able to provide us with type O whole blood. We maintain 4 units in our blood refrigerator down in the trauma bay and have specific criteria for the patients that would be eligible, and we're currently prospectively studying it. But yes, for the acutely bleeding male patient in particular, we're able to give a unit or a couple units of that whole blood.
Well, congratulations to your trauma system. That's terrific. But let's stay with the pulmonary system, or at least somewhere in the pulmonary system. And how about talking about tracheostomy? Has open tracheostomy been supplanted by percutaneous tracheostomy?
In my practice, Dr. Weigelt, I still perform both procedures, and I try to be a little bit selective in who I perform the percutaneous tracheostomy on. And specifically, I'm looking for patients that have pretty favorable anatomy and one in which if things go awry and we need to rapidly reintubate the patient, that's going to be feasible.
Do you have any idea how many trachs you do open versus percutaneous?
For me at this point in my career, it's probably about 50-50.
Wow.
Depending on a bunch of different factors. But I'd say about half of them I do perc and the other half open.
And one of the downsides of an open trach is that everybody thinks you have to go to the operating room. Is that true in your practice?
I would say it's not an absolute requirement, but I generally do tend to, if I'm doing an open, go down to the operating room.
And how about your perc trachs? Are those in the ICU or are those in the operating room?
Again, I will perform a perk trach at the bedside or in the operating room.
You got a preferred technique for your perk trachs?
I do. After really growing up with perk trachs during my residency, they were just getting started with the technique, and I unfortunately saw some procedures that went awry, and so my practice has been shaped by some of those negative anecdotes. But there also is some very good evidence, including the Denver study that was published in 2011 in the Journal of the American College of Surgeons, where they described 1,000 bedside percutaneous tracheostomies. I think they have some really good techniques, and so I do follow their suggestions for the most part, and use their technique as described.
And does their technique include bronchoscopy?
Their technique does include bronchoscopy, and I do that as well. Another piece of their technique that I picked up on is when you're pulling the endotracheal tube back, rather than doing it with visualization from inside the lumen of the endotracheal tube, they actually will perform, they describe direct laryngoscopy. I use a video laryngoscope to very slowly and carefully pull the endotracheal tube back under direct vision until you see that balloon just under the cords, and then you stop.
In your practice, do you see any contraindications to doing a perk trach?
I have a couple in mind as I'm going to assess the patient at the bedside. First, for me, I'm looking at the ventilator to see if they're even a candidate for an open or a percutaneous tracheostomy. What are the ventilator settings? Are they on a moderate to high amount of PEEP? What's the FiO2 set at? And I have a bedside test that I picked up from one of my colleagues where if there's debate back and forth between me and our ICU team about the readiness for the patient to have a tracheostomy, we'll just see if they would tolerate a little disconnect from the ventilator for about 10 to 15 seconds. And if they can't tolerate that, then I don't think that they're ready from an oxygenation or gas exchange standpoint. So provided the ventilator settings are acceptable, that they're not on overwhelming support, I then look at their body habitus. How obese are they? Is there a possible need for a proximal or distal XLT tracheostomy? And if that's the case, they're obese, might need a sort of a specialized trach, then I would tend to do those open. And then I'm also looking at their cervical spine. Can I adequately extend their neck? And then, as I mentioned before, are they a difficult intubation if the ET tube were to come out and I wouldn't have, I might not be able to get it in right away using an endoscopic technique.
Well, one of your relative contraindications about obesity, and you mentioned they need a different tracheostomy tube. You have any tricks or favorites that you'd like to share with our audience about one tube that seems to function well in that patient population?
If I suspect that they have a very thick soft tissue envelope or their torso length is extremely long, I'll actually go back and look at their CT scan and measure things out. And then I check the measurements on the standard either Shiley or Portex tracheostomy box to see how things line up. And if the tube is not going to go in easily and well within the parameters of my measurements, then I'll pick either the proximal or the distal XLT depending on what the mismatch is.
We have discussed, I won't say fought, but we have discussed benefits of perk trach over open trach for years. Are the benefits that we usually talk about, are they really real?
I think the primary benefit in my mind is the smaller wound size. There really can be significant wound complications, including bleeding, including wound breakdown, including even infection. So for me, I really do like the technique, and as long as it can be done safely.
There's one question about doing tracheostomy with a anterior spinal approach and suggesting that the perk trach is a better choice. How do you feel about that?
I think that's fine as long as the incision is fairly lateral on the neck. Even an open trach with anterior cervical spine hardware can be a little bit tricky. So as long as their spine has been stabilized and is able to be extended a little bit in discussion with the neurosurgeons or the orthopedic spine surgeons, I think it's fine to go ahead and perform a perk trach in those patients.
Well, let's stay sort of in the trachea, and there was a topic that was discussed by at least a couple of the CSAP 17 committees that did not make the cut, and the discussion was around a patient who is intubated, no infiltrates on chest X-ray, but is hypoxic. And the question and the discussion really was around, are there benefits from bronchoscopy in that patient situation? Lots of emotion, but not a lot of data. How do you view that problem?
I think that bronchoscopy is an important tool to be used in our ICU, but somewhat selectively. If the patient is significantly hypoxemic and doesn't have a lot of reserve, I am looking for some pretty strong indications for doing the bronchoscopy. In particular, do I truly need a BAL to diagnose a pneumonia, or could I do a tracheal aspirate? And I think the current guidelines from the IDSA suggest that a tracheal aspirate is sufficient in most patients. So I would think carefully about that if the patient truly is hypoxic.
And I'm assuming when you say tracheal aspirate, you're at least sending it for semi-quantitative or quantitative culture results. And I agree with you. It's what is now currently in the guidelines. So is that what you do?
Yes, with one exception, and that is if I've sent off a sample and the results are not clear yet, the patient has an abnormality on the chest X-ray, and I feel like I can be focused in my BAL, then I'll go ahead and proceed with the bronchoscopy and directed lavage.
I got to ask, so what's your cutoff for a positive semi-quantitative culture?
How did I know that you'd ask? So there's variability in the literature. I tend to use 10 to the fourth.
10 to the fourth. And that indicates a treatment course for that patient. Is that fair?
Yes.
Okay, and the treatment course that you're still using is 8 days, according to a fairly old study now.
Yep, I tend to measure my length of time in practice as a critical care physician by that study because I came out pretty soon after I started practice, and it's still tried and true. So unless they've got some horrific drug-resistant organism, and they indicated that Pseudomonas was perhaps the one exception in their study, but I've sort of broadened that to include, say, Enterobacter pneumonia. I think that's a pretty bad actor, and some of the others where the patient is just doesn't have much of a margin. I'll perhaps lengthen the course of antibiotics beyond 8 days.
Well, let's switch topics and let's talk about non-invasive ventilation. Hot topic for CSAP 17. And so I guess I'd start with do you have any protocols or policies regarding how you apply non-invasive ventilation in your unit?
So I do not have a policy. We do not have a protocol that we follow specifically, but our practice pattern is fairly consistent. And this was a topic for a journal club that we had about a year ago. And I think that's really been effective in lining up our practice pattern to where we're pretty liberal with using particularly high-flow nasal cannula post-extubation in our surgical ICU.
Okay, I'll come back to that. When you use non-invasive ventilation, what device are you most commonly using then?
So in our surgical ICU, we generally are using high-flow nasal cannula. We still, of course, do have the option of using BiPAP, but with the advent of Vapotherm and the other vendors for high-flow nasal cannula, we've I think, decreased our use of BiPAP.
So you have switched, in other words.
Yes. Yeah. We have definitely transitioned to using. I think OptiFlow is the one that we have in our unit, but yes, we switched to using mostly high-flow nasal cannula.
Well, let me talk about that high-flow oxygen because it was another CSAP topic, and so I caught from your comment that you and your group do believe it prevents some reintubations. Is that a fair statement?
Yes, that's exactly the benefit we're looking for. Okay.
Now, I'm sure you saw the article. It was a JAMA article about the combination of high flow and some technique. You mentioned OptiFlow, and they said the combination was better than just high flow oxygen alone. You have a thought about that?
I do. So the current systems both heat and humidify and provide the high flow. So it's pressurized, it's heated, it's humidified. So you get sort of the Cadillac treatment there with these new systems.
Another question that everybody wants to know is our dependence on non-invasive ventilation leading us to wait too long before replacing or placing, if it's index intubation, an endotracheal tube?
I think there's certainly a risk of that. So it does require that you or someone from your critical care team keep a close eye on the patient and not just fire and forget and, assume that all is well. So you have to circle back around and just make sure that the device is fitting well, that the patient's comfortable. I think it's also instructive when you go back by the bedside to be deliberate in adjusting your high flow settings. Now, you mentioned a protocol. Our respiratory therapists do have a protocol for titration, but I like to be involved in their protocol.
And when you come back around and you look at your patient, do you have any absolutes as you evaluate your patient that says, this isn't going to work, we just need to put the tube back in?
Well, there are sort of reasonable upper limits for the flow setting as well as the oxygenation. So I'm not hesitant to declare defeat and move towards reintubation. And
I know you think a lot about the physiology of the things we do, Jeremy. So can you give us your view of what the positive physiology of this very high flow oxygen infusion into the pulmonary tree is actually doing?
So I believe it's providing a little bit of back pressure, a little bit of PEEP effect, but it's variable from patient to patient depending on, how well can they cooperate, how much do they keep their mouth open, how well does this maintain the pressure within the system, meaning the system of their nasopharynx and the proximal trachea. So it's just providing a touch of a PEEP effect, even in the extubated patient.
You think it decreases the work of breathing at all?
I've seen it do that for sure, and so I think it does.
Well, it's certainly creeping into everybody's practice, and I'm certain your comments will help some people decide how far they want it to creep, I guess. Well, let's talk about another event that happens when we have somebody intubated, and that's trying to get them extubated. And for years we've talked about weaning, and some people have talked about ventilator liberation. Which term is used most commonly in your unit?
I think we stick with the weaning terminology, but certainly I've heard both in our ICU.
Do you have any policy protocol that you favor for how you do this?
Well, it's interesting. This is one of the many, but I think most important multidisciplinary approaches that come up in an ICU setting, where you need the nurse to turn the sedation off and the analgesia down. You need the respiratory therapist to come by to adjust the ventilator, and you need the physician to say, yes, this is an appropriate candidate for all of that. And you can use a sort of pre-planned protocol to make sure that happens on a daily or twice daily basis. So I think that of all the things we do in the ICU, that perhaps is the one that is the best example of how a protocol is important, useful, beneficial, and without one, you tend to sort of forget about it and not do it as consistently as you should.
The other thing I've noticed in most ICUs is that weaning used to be accomplished, at least the majority of it, with a mode on the ventilator called SIMV. And I find that mode almost disappearing from our unit. What about yours?
For sure. We generally would use a controlled mode of ventilation while the patient's in sort of the throes of their critical illness on vasopressors or sort of not certain what direction their clinical course is going to take. And for those where the clinical course is improving or where they're just on a for whatever reason, a short-term course of ventilator support, we tend to use pressure support ventilation almost exclusively.
And routinely use pressure support of some level when you have a patient on the ventilator?
Yes, so generally, depending on the size of the ET tube, between a pressure support of 5 and 7.5.
And now you mentioned sedation, and we all talk about sedation holidays. Again, some data recently out about how often we should do these. Originally, we talked about once, and then the study suggested maybe twice. How do you do it?
I currently still do it once a day, but sometimes for afternoon rounds, we'll do a one-off where, the patient was pretty close to passing, but maybe just needed an intervention or some sort of refinement or tweak to their course during the day, and that happened, and now, I think they're still ready for extubation. We have, of course, a 24/7 ICU. And, try not to do ultra-high-risk interventions late in the evening or overnight, but still, would potentially extubate a patient in the afternoon if everything had sort of been addressed during the day and they're ready for extubation. But I would say as far as our typical practice, we generally would not do a bunch of vent liberation trials a second time later in the day. But, perhaps our practice needs to change.
I don't know. I would say your comment is kind of what we do. And I guess the only thing is I think we all know that the longer you keep the tube in, the greater the risk of complications, including pneumonia. So it's a slippery slope that we walk, as usual, in the ICU. The other interesting topic that the committees discussed was the use of the cuff leak test. So I'll just ask you, do you use it and do you find it helpful?
So I know that our respiratory therapists almost universally check for a cuff leak. And only if there is a problem does it ever come to my attention. Or if I suspect a problem, I will deliberately go and check. But I don't go in and check 100% of the time because I know our respiratory therapists are checking 100% of the time and they'll let me know if there's a problem. The ones where I specifically go in and check are the ones where I believe that there's a risk for post-extubation stridor. Either they had a problem before they were intubated, they were a difficult intubation, or for some other reason I suspect that they're going to have laryngeal edema.
So your respiratory therapist comes to you and says, everything looks good to remove the tube, but there's no air leakage when I let the cuff down. What do you do?
Well, I take that under advisement. It really depends. So if I believe the result, then I will give a short course of steroids. I give Decadron. If I don't believe the result, then I'll go in and check myself. And if I'm then convinced, then we won't extubate and we'll do the Decadron. If I am able to then demonstrate an air leak, I ask about their technique and maybe use that as an opportunity to educate a little bit. And, if I feel comfortable that, in fact, the patient does not have significant laryngeal edema and will not fail immediately, then we'll proceed with extubation.
Okay, I'll push a little bit. So the dose of Decadron and how long, and do you really think it works?
So I have to go back and check my reference book, but probably I think it's 10 milligrams Q6, and I give 24 hours and then reassess in the morning.
Okay, and do you find that the cuff leak test is positive in the morning?
Most of the time, I would say yes. Yeah, so I've been impressed that it can work. Sometimes it doesn't, but many times it does.
And so it's either steroids or tincture of thyme, right?
Generally, yes.
And there is also some work about Heliox. Have you ever used Heliox in those situations?
My use of Heliox has been limited to trying to stave off a reintubation. So, I have used it a couple times, and it's worked. I don't know the exact percentages, but I've been impressed that it can help the patient feel more comfortable and sort of simmer down a little bit and not be so anxious. And I've been able to not reintubate a couple of patients that have been stridulous, but I've not used it in the setting of an absent cuff leak.
Okay. Well, let's leave the pulmonary system. Let's talk about some cardiac issues. Let's talk about some different rhythms and their cause and possible treatment. So You've got a patient who has got a monomorphic ventricular tachycardia with hypotension. So you walk in, you're at the bedside, you confirm that. What do you do?
Well, if they're truly hypotensive, that patient needs to be cardioverted. So, yes, I get the code card at the bedside and start making sure we've got some code drugs available and then hook them up to the machine and cardivert.
How about monomorphic ventricular ectopy without the hypotension?
In that setting, you've got an opportunity to hopefully suppress the ectopic beats, and I think a very familiar antiarrhythmic such as amiodarone can be beneficial.
Let's talk about bradycardia with hypotension. Many people use atropine, which has some terrible side effects. Are there other drugs that are useful in this situation?
I have to say I'm probably not the best person to ask about bradycardia outside of atropine. I will say that, and this may be interesting for your listeners, I've been impressed with a couple of patients that we've had in our ICU that have had a spinal cord injury and have sympathetic dysreflexia, and in that setting have sort of overaggressive vagal tone or unopposed vagal tone, and can have severe bradycardia and even bradyasystole arrest. And in those patients, I've started moving towards giving preemptive oral albuterol to mitigate the risk of that bradycardia. There's a report in Journal of Trauma from a few years ago where they described being able to actually avoid cardiac pacemakers in many of their patients that have that problem.
Well, that's actually good because I should have said bradycardia with hypotension in the spinal cord injured patient, because that's, I think, in the surgical unit, one thing that we commonly see. Atropine certainly can be used, and now we've got another drug. I have not heard that and have not used that. And atrial fibrillation, commonly seen in our older surgical patients. And do you have a first-line drug that you always give? Are you a rhythm guy or not?
I have to say I've been impressed by the evidence that suggests that rhythm control is not as imperative as perhaps we once thought, and that so long as you have the rate pretty well controlled, say a heart rate less than or equal to about 110, that those patients have very good outcomes. So I generally am reaching for, and for me, the first-line choice would be a beta blocker. I just have more experience with and comfort with using a beta blocker, and so I generally would reach for that as my first-line agent.
And cardioversion necessary in these people, or most of the time you find that is not necessary?
The vast majority of the time it is not. I have had to cardiovert a few folks that have become truly hypotensive, and I just felt like, chemical cardioversion was not going to act quickly enough, and so we get the pads out and go ahead and do an electrical cardioversion.
And there always seems to be a discussion between whether we should be using calcium channel blockers or beta blockers. You mentioned beta blockers. You feel comfortable with that? And does anybody in your unit push back and say, well, we should be giving them calcium channel blockers?
I've not seen any pushback, but you do have cases where the beta blocker is ineffective, and then you find yourself transitioning, at least for me, from one to the other. I have a healthy respect for doubling up on your nodal blockade, so I tend to not use both a beta blocker and a calcium channel blocker together without a cardiologist standing right at my side. I have had to do that on rare occasion, but you really can throw the patient into complete heart block with that approach. So I tend to start with the beta blocker. I'll titrate it up. If it's still not working, I'll then switch entirely over to a calcium channel blocker, specifically diltiazem as a drip. And then if that's not working, I then start to think about rhythm control. So that's for me when I start to switch over to, say, using amiodarone.
And then a question that seems to always appear on exams that we have to take throughout our careers is Torsades de Pointes. It's always talked about. So what is it?
So it's a phrase that refers to twisting of the point. So it's a description of the electrical printout on a rhythm strip where the cardiac rhythm sort of fluctuates around, or the amplitude of the rhythm fluctuates around a center line. It's potentially a malignant arrhythmia treated by a bolus of magnesium, and it can be very exciting because the patients generally are rapidly decompensating, but it also can be quite responsive to medical intervention.
So magnesium is the treatment, but what precipitates it in a surgical patient?
So, some of the drugs that we give, including, say, Seroquel or anything that can prolong the PR interval, can lead to this.
So some of our sedative drugs are culprits in this when we're trying to control a hyperactive patient.
And that's why they've got a black box warning. Got to be very careful.
Well, let's talk about some other drugs that I find ourselves using almost on a daily basis. And I just ask you to give us your view of the drug, how you use it, and what we should know about it. So let's start with propofol.
Propofol is, I would say, basically universal in our ICUs here in the United States. It's an incredibly effective sedative, but it does have some downsides, and most commonly people think of it causing hypotension. So in a patient with an acute traumatic brain injury, you may want to be a little judicious about starting that at a high rate or high dose early on until you're sure that their hemodynamics are okay, because the last thing you want to do is cause hypotension in that patient. But it's a very effective, highly reliable, very consistent sedative.
Now, the argument always revolves around whether it's a sedative or an analgesic or both. How do you feel about that?
I'd have to probably debate that with one of my anesthesia colleagues. I see it as just a go-to drug, so I guess I'm not as concerned about what exactly it's doing. But I think that, I've not seen patients with a lot of sort of adverse effects from a mental status standpoint in terms of either PTSD or something like that. But I think it's potentially an interesting topic for investigation.
Okay. And do you monitor lipids when a patient is getting an infusion of propofol for greater than 3 days?
We do. We'll do spot checks, every couple of days just to be sure that they're not getting hypertriglyceridemia. And we also tend to do that, in the setting of TPN. So if we've got a patient on propofol and fat-containing TPN, we absolutely do and pay close attention to it.
And then the other question that everybody knows about propofol is the propofol infusion syndrome. Have you ever seen a case? And can you tell us a little bit about how you recognize it?
Unfortunately, I have seen a case, and it is incredibly dramatic. Very similar to TACO that we were discussing earlier, where it is almost unmistakable, but you have to be thinking about it because it can occur in patients that are critically ill and have other explanations potentially for what you're seeing. The typical propofol infusion syndrome heralds with an unexplained metabolic acidosis. And for me, that has been the tip-off I think I've seen 2 cases. One was, very memorable and dramatic, and the patient got significantly better fairly quickly after we turned the propofol off, over several days. But the challenge is identifying it in a patient that's critically ill for other reasons. And
so the unexplained acidosis is the tip-off.
That was definitely the tip-off in the cases I've seen.
How about dexmedetomidine? Where does that stand in your unit these days?
So I have a little bit of a love-hate relationship with Precedex or dexmedetomidine. I love it in the patients it works in. The challenge is, finding the right patient and, buying enough time for the medication to actually take effect. So for me, I tend to use it in patients where they're either incredibly awake and hyperactive and perhaps a risk to themselves, but close to extubating. So we're stuck with this choice of either a rapid sequence extubation, I call it, or sort of a smoother transition to wakefulness using dexmedetomidine. And in some patients, it is very effective. It just takes a little while for it to come up to the therapeutic level. I tend to be a little nervous with the bolus dosing up front with the concern for bradycardia. So I tend not to bolus, so it takes a little while to take effect. But in the patients where it works very well.
It's very interesting. We have an active discussion between our medical and surgical intensivists. Neither one of us use a bolus infusion, but bradycardia is much more common in our surgical patients than in the medical patients. And the only difference that we can find is that the units are separated by 5 floors. So we have no explanation for that, but we definitely see a different incidence or frequency of bradycardia with the drug when it's used. Very interesting. All right, let's take another drug that seems to be gaining in popularity, and that's ketamine. How do you use that in your unit?
Wow, that is a can of worms. It has to do really with the nurse licensing and what are they allowed to titrate and not. So I've had experience in 2 different units. First, in the military ICU I worked in San Antonio, where there was such a sense of urgency to get this drug in use for our combat casualties that had pain syndrome problems, that we jumped through all the hurdles and hoops and actually got it approved for use in our ICU. And I will say that for those patients that were on kilos of morphine and fentanyl before, it was incredibly effective at allowing them to sort of break that cycle of pain and really get out of that incredibly high-dose narcotic usage situation. I have to say in Philadelphia, I have not seen sort of the same pressing need for it, so we have not actually gone through all the steps of getting it approved for use as an infusion by our intensivist. Now, the pain service, I believe, does use it and will occasionally admit a patient to the ICU where they're involved in titrating. So it's a much more limited use.
And when you were using it, were you using a drip?
Yes, it was a continuous infusion.
Yeah, we use a drip, and we have found it to be very helpful in keeping our opioid use at least much less than it was in the past. So I think it's something that we're probably all going to see more of as time passes. All right, so what about benzodiazepines? I talk about a love-hate relationship. I think the entire physician community has had that relationship with this drug. So where does it stand in your unit?
So I use benzodiazepines very infrequently, and we mentioned hypotension as one of the main side effects of propofol. If I have a patient who is tenuous from a hemodynamic standpoint and I really feel like the propofol is contributing to the hemodynamic instability or at least clouding the picture, then I will go with a very low dose, very intermittent benzodiazepine. I avoid benzodiazepine infusions as much as possible and really try to minimize the dose.
Well, let's drift into more drug use, but for sepsis treatment. And I think everybody knows about the Surviving Sepsis Guidelines and pressors. And I've got a little different question. I think we all know that norepinephrine is the primary pressor that the guidelines suggest, followed by vasopressin. But is there any use for all those others that we used to use, epinephrine, dopamine, dobutamine? Do you ever deviate from the guidelines?
So in my practice, I do use epinephrine intermittently. I can count on one hand the number of times I've used either dopamine or dobutamine. I just find that I'm able to achieve my endpoints with the combination of, as you mentioned, generally norepinephrine first, followed by vasopressin as an adjunct, and then in select cases, the addition of epinephrine.
Okay, and then the other question that everybody wants to know when they're talking to a critical care expert is, you've got a patient on norepi and vaso, they're getting better. How do you remove those 2 drugs? Very
carefully. No, I generally do not titrate the vasopressin to any degree, with the exception of if they're, basically normotensive, I'll turn it down by half just as a sort of a test run. The norepinephrine, you can adjust minute to minute, hour to hour, and I tend to leave vasopressin on in the background, adjust the norepi up, down, and sideways as much as I need to. And then as they're coming off, generally the norepinephrine will be at a very low dose or even off, and then I'll turn the vasopressin to half and see if they can be off everything.
There was a recent article that was intriguing, to say the least. The article is about adding vasopressin to treat hypovolemic shock. Comments?
Well, having seen the study unfold firsthand, I think that its goal is not so much to correct the hypotension, although that was their endpoint, but the theory is that you're supplementing a hormonal deficiency, that the endogenous vasopressin stores have been released and there is no more, and now we're essentially supplementing that hormone. Now, the endpoint for this study, it was the AVERT shock trial, demonstrated that your need for blood product resuscitation was dramatically reduced in those that received this vasopressin supplementation.
So you're a believer and an early adopter?
I am a believer and probably an intermediate adopter. There are just some pragmatic elements, and that is, the drug has to be in the Pyxis in the right dose. It's a 4-unit bolus followed by a 0.04 infusion. So, the 0.04 infusion is up in the pharmacy. By the time I've given my whole blood and I'm starting the master transfusion protocol, I may get the 0.04 infusion by the time they get up to the ICU. And then we can have our anesthesiologist give the 4-unit bolus. So I would say, this article just recently came out. It's being sort of mulled over by the surgical community. It came out of the University of Pennsylvania where I practice, and it is coming into use, but, it's not 100% of the patients that we have that get this.
And it's really just those in, I don't want to call it severe hypovolemic shock, but those people who you are expecting to use, let's call it a massive transfusion protocol on?
Yes, it's the ones that clearly have bleeding. You're probably going to go to the operating room for surgical hemostasis or possibly to angio. But yeah, the ones where we've activated our whole blood and are calling the blood bank for the master transfusion.
Well, another topic that got great discussion among the committees was alcohol withdrawal, and it seems like phenobarbital is making a comeback. Do you have any comments?
I have a healthy respect for phenobarbital. I see it as sort of a Hail Mary, and I think there are drugs that are more tried and true and that at least I have more practice experience with. In particular, we use either the CWAP protocol or the MINDS protocol to score the patient in their alcohol withdrawal condition. How severe is it? And do they warrant medical therapy? I think it's important to not do that in a silo or to just blindly give the medication. So I tend to have the nursing team do the score and then call our ICU team if the score is starting to creep up into what would normally be the therapeutic range for a bedside assessment. And then the medications I tend to use Ativan as my go-to, with one exception, and that is in the TBI patient where I still want to continue to follow their neurostatus and mental status exam, and it's very important to sort of identify deterioration that might indicate an intracranial bleeding progression. I'll tend to use oxazepam or Cirax.
So this is one condition where you still are using benzos.
It is, yeah. You found my one indication for benzos.
Okay. And how about beta blockade or clonidine for these hypermetabolic alcohol withdrawal patients?
Well, I like those as salvage options, in particular clonidine. I think it has some physiologic benefit. You have to be careful with hypotension. But and then I would say, for me, that might be a case where phenobarb would be a consideration. If they were, scoring high on their CWA or MINDS protocol, and I was given truckloads of benzos, or maybe even before truckloads, a lot of benzodiazepines, and it just was not effective. I would also think about another problem. Do I have the right diagnosis here? There's this hyperactive delirium related to something else. Am I missing something?
Good point. We always need to worry about that. And then, so if you like clonidine, do you use Dex in these people?
I think I may have used that once for that indication, so not commonly, but they are comparable, and so it makes sense. I just have not had occasion to do that.
I got one question, or maybe a couple, about glucose and nutrition. So we all know that enteral nutrition is best, but is there a glucose goal that we all agree on, or are we still a nation divided?
Well, this has been a very interesting saga through my critical care career, going from not really paying attention to it to paying perhaps too much attention and tightening up the parameters too much, resulting in hypoglycemia and adverse neurologic outcomes. So now I think finding, sort of a sweet spot on the spectrum. So my current practice is to target something less than 180. You could debate, maybe 200 is the new 180 or maybe even 220 is the new 180. But I think if you're shooting for something less than 150, you're putting your patient at risk for significant hypoglycemia and the adverse neurologic outcomes that go along with that.
Yeah, it certainly has been a moving target, and I would agree with your range, and we also use less than 180, or right around 180 as our goal. Another question then, enteral nutrition. You've got a patient who is just coming off a resuscitation. You've got a feeding tube to use. Do you start them on trophic feeds immediately, or do you just try to ramp them up as quickly as possible?
I have to say I have a healthy respect for complications from enteral nutrition. Specifically, if the gut is not quite ready for nutritional support, you can continue to cram feeds into the intestine, and it won't progress downstream, and you'll end up with what I call a tube feed Bezor. And you'll have outstripped the patient's intestinal blood supply, and you'll be in the operating room doing a bowel resection. Now, I have to say that tends to occur most commonly in the setting of a big foregut surgery, so say after a Whipple or a gastrectomy or something like that. So you have to be very careful about just cramming tube feeds in. That said, I love tube feeds. I think, it's very physiologic, and I think, in comparison to TPN is, for me at least, preferred if the GI tract works. But you have to be a little careful about, being sure that the GI tract is working and able to receive the nutrition you're giving it.
So in that situation where you think it might not be ready, are you just sort of dripping in 10 cc's an hour or something and calling it trophic feeds?
I do use trophic feeds, but I tend to do it in patients where they've resuscitated completely, their lactate is normal, they're not on vasopressors, certainly not escalating doses. If I have any question and they're nutritionally deplete, then I will go ahead and start TPN until I can be sure that the GI tract is working.
Well, I almost started asking you this next question when we were talking about taco, but I decided I would save it to be our last question regarding how you assess a patient's response to fluid administration. I think every CSAP committee, that's 9 of them, had at least one question on this topic, and it appeared that the technique was always different. So can you help us wade through the various methods that people have said we should be using today to assess a patient's response to fluid administration? And then, I'm going to ask you, which one do you favor?
If I ever have any doubt that our specialty is going to be in crisis or not in need, I just think about this topic, and I think this is where we can really shine to personalize the patient's therapy. And it goes back to that age-old question, is the patient wet or is the patient dry? And they generally don't come with a sign on their forehead telling us which one it is. So it's very useful to have these techniques to sort things out. And I guess I'll just start with the last thing you said, and that is, what do I do? How have I distilled this vast body of literature down to my practical day-to-day practice? I have been very impressed by the ultrasound techniques that show me a picture of what's going on in the patient's vena cava or what's going on in their right heart. And so I've run the whole spectrum from A-line tracings to indwelling TEE probes to intermittent bedside ultrasound. And I think the most practical and, for me, cost-effective approach is the intermittent bedside ultrasound. Not, again, fire and forget like, sometimes we do, but to go back and reassess after you've implemented a therapy. So the specific technique I use is either transthoracic or transabdominal views of the vena cava as it passes through the liver and up into the right atrium. I find that technique is useful on both intubated and spontaneously breathing or even extubated patients. And for me, I also find it has great teaching value in that you can show the residents and fellows imaging techniques. You can talk about how to do some more advanced measurements on the images that you capture. I think there's just tremendous value to the point where I think in most, if not all of our ICUs, we should probably have an ultrasound with us on rounds.
You didn't mention straight leg raising, such a simple technique.
If I'm in an austere environment where I don't have an ultrasound handy, then I have done that. And a threshold cutoff of, say, a 10% increase in blood pressure as you raise the legs up 45 degrees can be sort of a poor person's test, I would say. But, we've got these sophisticated ultrasound machines. It's good to learn how to use them. And I like, the visual feedback I get of, what's the vena cava actually doing. For me, as a very visual person, it makes a lot of sense to use the ultrasound. And
in our critical care patients, how often are you stymied with bowel gas or other problems that you can't properly visualize the IVC below the diaphragm?
I would say it's pretty rare. Thankfully, with getting more comfortable with a number of different imaging windows and techniques, you can go substernal, you can go far lateral on the patient's right side, you can go parasternal, and through a combination of all those, usually you're able to get at least one view where you can see that vena cava. Or if you can't find the vena cava, then look at the right heart. What's the right atrium doing?
And when you're talking to your residents or your fellows and you're explaining what you're looking at, what's your cutoffs for having a patient who you think would be responsive to a fluid bolus?
So that's where you start to get into the nuance of, what's going on with the patient outside of their volume assessment. Are they intubated and spontaneously breathing? Are they on a full control mode? Or are they extubated? And I have different thresholds for those. The specific technique I like to use is either right lateral going through the liver or subxiphoid, where I get a view of the vena cava just around or perhaps a little caudal to the hepatic vein entry point. I'll take an M-mode view, and then in that M-mode view, you'll have both inhalation and exhalation. And you take your calipers and just measure the distance of the vena cava in those two different cycles, and then look for the delta. And for me, the intubated patient on positive pressure will have less fluctuation, and so your threshold is a little bit lower, between 10 and, say, 15%, usually about 12%. So if their variation is more than 12%, that means that they're likely to be volume responsive. And then if it's less than 12%, then they should be volume replete. Conversely, in the extubated patient, you won't have that higher intrathoracic pressure. The venous return will be better, and so the volume responsive patient will have more fluctuation. So 25% is usually my threshold for the extubated patient.
And obviously, if you see a collapsed vena cava, that tells you the fluid responsiveness versus a plump one.
Yes, so you've got your answer there. If it's collapsed, then they need more intravascular volume.
Well, it's been great discussing these topics with you this morning, Jeremy, but I think our time is about up. I really do thank you for your contributions to CSAP 17 and to CSAP Audio Companion now. So I'll give you the chance for a final word. Any comments about either of the products for our audience?
Dr. Weigelt, I appreciate the opportunity to have this discussion with you, and I feel that the CSAP product is incredibly rich and comprehensive, and so I think it's very useful both for the practicing surgeon and also the surgical trainee. So I highly recommend all the CSAP products.
Well, I thank you very much, and I really do thank you for your contributions, because without all the author contributions, there'd be no product.
It's my pleasure, Dr. Weigelt.
That's it for this category of the CSAP 17 Audio Companion.